recording so I don't forget. Sarah and Jean, since we can't see you, can you hear us?
Yeah. Yes, I can hear you. Thank you.
Well, Sarah, you might be the new one on the call, so we won't ask you to introduce first, but maybe we'll do quick introductions here and we'll save our speaker for tonight for last. I'm Lori Byron, and Rob and I are in central Montana, and a pediatrician and an internist, largely doing climate work these days. I'll hand it to Robin.
You're muted.
Sorry. I'm Robin Cooper. I'm located in San Francisco, California. I'm a psychiatrist. I'm on this group, and although have missed several sessions, and I also work with a group and I'm co-founder of Climate Psychiatry Alliance, a group that is dedicated to the mental health aspects of climate change.
And you're handing it to?
I will hand it to Bob.
Hi, I'm Bob Kitchen, retired family physician living in Fairfax Station, Virginia. And in addition to the CCL health team, I'm a member of Virginia Clinicians for Climate Action. Jean, I'll tee you up.
Thanks. I'm Jean Klein. I live in St. Louis, and I'm a dermatologist. And I'm mostly involved with CCL, but also do some work with Environmental Voters Project and Elders Climate Action. So I see some overlap with some of those other groups, and I've been a member of Union of Concerned Scientists for decades. Guess I'm supposed to pass it on. Let's see. Who else has not? Did I see that? Who else has not? Kathy, have you spoken?
No. Okay. I'm Kathy Price. I'm the speaker tonight. I'm a retired rheumatologist in Fairfax, Virginia. And I'm been involved not very actively with CCL for many years, although I did do advocacy for them. And I'm a member of the Virginia Clinicians for Climate Action, and work with Bob on advocacy there. Oh, and I'll pass it on to Sister Pat.
I'm Sister Pat from Louisa, Kentucky. I'm a retired surgeon who worked outside the country and then in Eastern Kentucky. I'm involved with CCL and some of the subgroups with that, as well as like our local health department for health action and that.
We'll send it to Yvonne.
Good evening, everyone. Yvonne Collins. I am in Chicago. I'm a gynecologic oncologist by training, also a 2022 Climate Health and Equity Fellow. I participate with CCL in addition to the Illinois Clinicians. And I'm not sure, Lisa, did you go? I'll pass it to Lisa.
Thank you. I'm Lisa Delbono. I'm active in CCL and Michigan Clinicians for Climate Action, and I'm going to pitch a sign-on and put it in the.
You're muted.
You went on mute, Lisa.
Whoops. Okay, so I'm going to put the sign-on in the chat, and just to give you some background, Enbridge is an oil company out of Canada that has a pipeline. They have many pipelines, but one of them goes through the Great Lakes, the Straits of Mackinac, really, really deep. There's actually 2 pipelines. It's over 50 years old. In fact, it's 70 years old almost. And they've been trying to decommission it for a long time, but now they're proposing a tunnel, which is kind of a way to keep it going for another 20 years or so, because that's about how long, at least a decade, to build the tunnel. So they asked that we write a comment to the Army Corps of Engineers about why building a tunnel is not such a great idea. And that's what the sign-on is for. One is for individuals and one is for organizations. So if you guys are comfortable signing that certainly the Great Lakes is 18% of the world's fresh water supply, so it affects us all. And I don't think Sarah's gone.
Hi, I'm Sarah. I am calling from outside Chicago. I work full-time in rheumatology research and I also do political organizing on the side. So really excited to be here. This is my first event with the health team, but I'm also involved in the wildlife action team.
Thanks. How appropriate for tonight. So Kathleen half introduced herself. I love that she got interested in public health because of her experience in the original Salk polio vaccine trial. So I'm sure she's listening to some of the other public health issues here recently with bated breath after her brother had polio. And she went to University of Michigan. She interned at Henry Ford, did internal medicine at Wayne State, and then did rheumatology at Wayne State and at George Washington University. She's worked as an internist and as a rheumatologist, and she's been active in climate for quite a while. So we pushed her to talk on this subject, and quite honestly, I've never heard a talk on this subject, so we're excited.
Okay.
And maybe let's let Cynthia say hi, and then we'll hand it over to you, Kathy.
Hi, everyone. Sorry to be late, but we've got our voting for climate and health meeting that bumps right up against this. So
Yeah.
I'm looking forward to this. Thank you.
It's all yours, Kathy.
Okay. All right. So I'm technically not very good, but well, where to go? Here it is.
You want to see if you can increase the volume a little bit where you are, Kathy? Is everyone else hearing her well? It's kind of faint.
Let's see. Oh, down here maybe. No, that's not right. Well, can people hear me now? Can you hear me now?
That's better.
Okay. Oh dear, I can't, oh, here it is. From current slide, okay. I'm trying to make it bigger. Can you see the slide?
Yeah, you should be able to hit the from beginning button.
Oh, from beginning, okay.
That usually makes it.
Resume slideshow.
Kathy, you're
Now,
trying to,
having tried it before and messed it up, right?
Kathy, I think down in the lower right corner where you see the sliding bar to increase your size, just to the left of that, that icon looks like a screen. I think that'll expand it. You know, click on that. Never mind.
Well, most of them are pretty big. Can you see it pretty well?
Yes.
Yes.
Okay. All right. So, let's see. What's this? Oh well. I'm not going to mess with it because I might erase the whole thing. That's about how comfortable I am with it. Okay. So, basically, Lori asked me to talk about air pollution and immune-mediated disease. And frankly, I wasn't very aware of that. And part of the reason for that is most of the studies are fairly recent that seem to show much effect from pollutants, but the evidence is mixed. There's a number of studies that show that living near a highway is a risk factor for developing rheumatoid arthritis. But subsequently, then they started doing studies tracking exposure to specific pollutants, like PM 2.5, PM10, nitrogen dioxide, sulfur dioxide, and ozone, and trying to correlate them, exposure to them with onset or prevalence of rheumatoid arthritis. And they have shown conflicting results. Most of the early ones didn't show any evidence, but more recently they seem to show some effect, although some studies saw, well, it's PM 2.5, and others say, oh, it's nitrogen dioxide, and others say, oh, it's ozone. So, it's hard to know that really what's going on. But you all probably know that immune-mediated diseases are diseases of chronic inflammation with unknown etiology, and they're felt to have both genetic and environmental causes. So why consider this subject? Are you seeing my slide?
Yeah.
Actually? Okay. So cigarette, you're seeing that, why consider this subject that I'm, okay, good. So cigarette smoke has been shown to be one of the most potent risk factors for rheumatoid arthritis and lupus in epidemiological studies, in animal studies, and in vivo studies.
Wow.
And smoking doubles the risk of rheumatoid arthritis, certainly in men, and especially for people who have the so-called shared epitope, which is on gene HLA-DRB1. And I've seen, generally I heard that it doubles the risk. There was one reference that said it's women smokers have only 1.3 times the risk, but I'm not sure. I think it may be twice the risk for them as well. So, and smoking is also associated with a poorer response to anti-TNF therapy, such as infliximab. So it seems to be really a problem for people with rheumatoid arthritis. And then cigarette smoke has many chemicals in common with polluted air. You know, it has the fine particles, volatile hydrocarbons like benzene, heavy metals, the gases, nitrogen dioxide and sulfur dioxide, and others. And these substances can cause tissue damage, which leads to the release of nucleic acids and other inflammatory chemicals such as interleukins like interleukin 6, interleukin 17, tumor necrosis factor alpha. And then the T and B cells can become sensitized to self-antigens, and then you can get chronic inflammation, autoreactivity, and tissue damage. And there are also other known associations with rheumatoid arthritis, such as inhalation of silica. So minors with silicosis have a high prevalence of RA, and inhalation of mineral oil, again, an occupational exposure. So insult to the lungs appears to be an entryway into inflammation that then affects the joints. Now, I was trying to limit to write down sources, and again, I'm a little challenged when we come to technical things. So that 8 is referring to a source way back down there. Let's see. And so this is a little overview of reputed pathogenesis of RA. And I don't really want to go into the whole thing, but you can see there's multiple pathways, that the fine particles have free radicals that then can activate various chemicals in producing TNF alpha and the interleukins, and that recruits the monocytes and then dendritic cells, and you get the T cells that are autoreactive, you get antibodies, and they can attack the joint with inflammation and then erosion. The free radicals can directly cause bone erosion. Also, when things get in the lungs, they can cause citrullination of proteins and peptides, which then cause you to get antibodies against the citrulinated proteins and peptides. And these antibodies are seen in about 2/3 of the cases with rheumatoid arthritis. There's sort of 2 sets of rheumatoid arthritis. There's the people that have those antibodies and the people that don't, and they behave somewhat differently. And these antibodies have been detected like 5 and 10 years before people develop inflammation in the joints. So they're felt to be very important etiologically and can be a marker for somebody who's going to go on and get rheumatoid arthritis. And these are especially seen in people who are smokers, especially if they have that shared epitope I talked about. And then also, one of the studies said that air pollution can reduce UV light because it just interferes with the light being absorbed, which leads to lack of vitamin D being transformed to 125 hydroxyvitamin D, and that actually, that the active vitamin D helps suppress some of this immunity, according to one of the studies. This slide is from Isuma, which is down below Michael Isuma. Anyway, so the first study looking at distance from a highway as a risk factor for rheumatoid arthritis was done from the Nurses' Health Study. And it was done by Jamie Hart. At that time, when she did this study in 2009, when she published it, there were about 90,000 subjects. They had been enrolled in 1976. And then their place of residence was evaluated in about 2000. And then they, 30% of the people, excuse me, I'm sorry. People who lived less than 50 meters from the highway had a 30% elevated risk of rheumatoid arthritis compared to people who lived over 200 meters away. And there was a stronger risk among non-smokers, which they felt was because smoking is such a strong risk factor. It can mask other causes of rheumatoid arthritis. The hazard ratio for these people was 1.6 compared to the people that lived over 200 meters away. And then the 95% confident interval I listed there. Risk from smoking is over 200%. So it was felt to overwhelm and mask the risk from air pollution. And no measures of pollutants were done at that time, but there had been a large body of literature developed using distance to roads as a measure of traffic exposure in studying effects on cardiopulmonary disease. So then there was another study done in British Columbia in the Vancouver, Victoria area, which is an area that doesn't have that much pollution. There were 678,000 residents, and they were looked at after they'd been there at least 5 years, and to see who had rheumatoid arthritis onset after 5 years of residence. And again, people who lived close to the highway, less than 50 meters, had a 1.37 hazard risk compared to those who lived over 150 meters away. Interestingly, if the people had a lower socioeconomic status, they looked at the average income in that little area, their hazard ratio was 1.73. And low socioeconomic status is a risk factor for rheumatoid arthritis. We're not quite sure why, but there is a risk factor. Part of it may be there's a little bit more increased risk of smoking in people of lower socioeconomic status. But in this case, we don't know about individual smoking history because there was no history done of the people one-on-one that way. When people were in between 50 and 150 meters away, they had an intermediate risk of rheumatoid arthritis. They did look at levels of PM2.5 and PM10, the gases and noise, and none of them correlated with onset of RA. They actually found that ozone was associated with an increased risk of rheumatoid arthritis with a hazard ratio of about 1.26, but the ozone concentration, ground level ozone concentration was highest in the suburbs for some reason. So there, it's hard to make sense of all this. Anyway, limitations were that they had generally low levels of pollutants in this region. There was only 5 years of exposure, and that's probably not enough. And there was no individual smoking history. Then the Nurses' Health Study looked at it again in 2013. By that time, they had over 110,000 subjects. They looked at PM10, PM2.5, nitrous dioxide, and sulfur dioxide from EPA data. and tried to correlate with where people were living. And overall, they showed no evidence of increased RA with these pollutants. And in fact, the hazard ratios were usually less than 1. There were some limitations to this study. For one thing, the exposure data didn't begin until 1985, and the study began in 1976, so they don't really know what the pollution was earlier. And they hypothesized that maybe the currently used measurements of air pollution exposures are too imprecise or not strongly associated with the etiologic agent, that it's some other agent, not these things that they were testing for. But why things would be in different concentrations, different ways, it's not clear at all. Also, pretty much the subjects were employed nurses at the time that the study began, and so the socioeconomic status was fairly high, and it wasn't a really generalizable study to the whole population. Then another study looking at pollutants. This is in Sweden, in Stockholm County. It was done by the same researcher, Hart, at the same time, 2013, and there were relatively low levels of pollution there. This was a nested case control study, so there were 1,497 cases of RA onset during the time, and 2,356 controls that they matched for sex and various things. And they measured the local levels of PM10, not 2.5, nitrogen dioxide and sulfur dioxide. This study showed no evidence of effect of PM10. And there was a modest increased effect of sulfur dioxide and nitrogen dioxide, but it wasn't significant after adjusting for education and smoking. Although there was a non-significant but stronger risk with people who were anti-citrulline protein antigen negative, antibody negative rheumatoid arthritis. So that smaller subset and had less than university education. They said that their nitrogen dioxide was felt to be due to traffic, and their sulfur dioxide was due to home heating because they used oil that had quite a lot of sulfur in it. So the bigger effect was, anyway, they were the nitrogen dioxide and sulfur dioxide. Then there was a study in Italy. It was a retrospective observational study on a nationwide data set of women and men all over Italy with 81,000 plus subjects. And actually this data came from a fracture risk assessment tool that people had, or they're trying to figure out how prone they were to fracture, putting in their data on bone density, and also the people would put in the diagnoses. But it wasn't like necessarily a rheumatologist was confirming the diagnosis. And also the population was skewed to women greater than 50 years, although there were some men and all that. Then they got levels of PM10 and PM2.5 from the Italian Environmental Protection Research Institute. And they found an association. Every 10 increase in PM10 was associated with an incremental 7% risk of autoimmune disease. And exposure to PM10 above, they picked PM10 above 30 and PM2.5 above 20 as unhealthy levels. And exposure to them was associated with 12% and 13% higher risk of autoimmune disease. The PM10 exposure was associated with an increased risk of rheumatoid arthritis. The 2.5 exposure was associated with increased risk of rheumatoid arthritis, connective tissue disease, and inflammatory bowel disease. And their conclusion was that chronic high levels of exposure to traffic and industrial-derived particle pollutants was associated with a 40% higher risk of rheumatoid, 20% higher risk of inflammatory bowel diseases, and 15% higher risk of connective tissue diseases. So this, they were pretty impressed with this. And this study was done this was presented at EULAR, the European Union League Against Rheumatology, their conference in 2022. So this is a very recent study. Then there was another recent study, more recent study done in Taiwan, which showed that air pollution increased risk of RA as measured by nitrogen dioxide. Again, it was nationwide. They used their national health insurance and the air quality monitoring database. So both this one and a subsequent one, they had everybody in the area that was being looked at, and they were measuring both PM 2.5 and nitrogen dioxide. And they showed that the nitrogen dioxide was associated with an increased risk. You can see they divided it into 4 quartiles, and comparing to the lowest quartile, the second quartile had a little bit of increased risk. The third had significant 1.63, and the fourth had a little bit less, but 1.49. And I've got the 95% confidence intervals in parentheses here. For PM 2.5, there really wasn't a association. Then there was a big study in Quebec where they looked at an open cohort study of over 6 million adults. And again, this is published in 2022. This was not looking, they weren't looking for rheumatoid arthritis, but they were looking for other systemic inflammatory diseases. And this study, people had to have lived in Quebec for at least 4 years before the study. And they looked at hospital and physician billing records from 2000 to 2013. And they got the pollution data down to a 1 square kilometer area, which is pretty good with a governmental source. And they followed these people for an average of 10 years. At this time, the pollutant levels were pretty low in Quebec. That average PM 2.5 was 7.5, ozone was 24. But what they found was that there were higher risks for systemic immune disease with PM 2.5 exposure, about 20% increased risk, but not with ozone. The hazard ratio ranged from 1.2 to 1.29, depending on how many things they controlled for. And the most common diseases, diagnoses were diffuse diseases of connective tissue disease, polymyalgia rheumatica, and polyarteritis nodosa, which is a pretty specific diagnosis. And then less commonly, they had some other necrotizing vasculopathies. A few patients had lupus, Sjogren's, dermatomyositis, scleroderma, and some others. Let's see. Then there's another study looking at air pollution and rheumatoid arthritis disease activity. This was in Kuwait. They have a registry for rheumatic diseases in Kuwait. And they were measuring disease activity score, which is a clinical, asking patients how they're feeling basically, plus examining 28 joints. And also the clinical disease activity evidence index, which again is asking people how they feel and are functioning, and also includes a lab test of C-reactive protein. This study was done from 2013 to 2017. They were measuring PM10, nitrogen dioxide, sulfur dioxide, ozone, and carbon monoxide. And they followed 1,651 patients with RA and had almost 10,000 follow-up visits. So this showed increased disease activity score by DAS score in patients exposed to sulfur dioxide and nitrogen dioxide with a p-value less than 0.01. But no increase in DAS28 with the other pollutants. C-dye did show an effect on those gases and also on ozone. from ozone. So in summary, I mean, there does seem to be an adverse effect of air pollution on immune-mediated diseases. The effect of proximity to traffic seems to point to a real effect. However, we have all these contradictory results, you know, which pollutant, and the earlier studies didn't seem to show that pollutants were harmful, but the later ones all seem to show that one or the other is harmful. And somebody raised the point that they may be looking at an ideologically relevant, may not be looking at the ideologically relevant pollutants, and maybe it tracks differently than the ones that they've been following. There were some studies that were done where there wasn't much pollution or the smoking status wasn't known. And since smoking is a more potent risk factor, it seems to mask the effects of pollutants and make it hard to really figure out what's going on. They also point out there's trouble with knowing how much exposure a given patient really got. You know, are they at their address? How much are they at their address? Are they traveling other areas? Is there indoor air pollution, et cetera? So there's Michael Asuma in the last reference talks about the need for more studies in lower and middle income countries and also countries where there is more pollution. And in general, there's more pollution in lower and middle income countries. So, you know, what's showing in Vancouver isn't necessarily all that indicative of what's going on in countries where there's much more pollution, like India. And also, we need to study indoor pollution from burning fuel for cooking and heating in residences, which again happens in the primarily in the lower and middle income countries. So that's what I found. Let's see. Are there any questions? I know it's a lot of stuff, and I hope it wasn't too fast. Yes, Robin.
Thank you. As the comments that I put into the chat indicate, no, you don't have to follow it. You were busy. You were busy. But I was really glad to see that unreadable chart that you gave, that you walked us through about the inflammatory process.
Yeah.
And my comments imply that maybe this inflammatory process that you're seeing in the diseases that you've spoke about, particularly the rheumatologic arthritis and the other diseases, may have the same pathophysiology or the same drivers of some of the inflammatory impacts that we're seeing in brain diseases. And I'm wondering if in the diseases that you study, if there's a coincidence of brain diseases, actually that in the neurology or air pollution literature and brain literature, there seems to be indications that there are impacts across the entire developmental spectrum from prenatal to elderly. And I'm wondering if you're seeing any overlap and coincidence of diseases.
Well, you know, I'm not aware of an increased evidence of dementia and things like that in rheumatoid arthritis, although they certainly there's increased risk of neuropathy. And but the connective tissue diseases and the vasculopathies, I mean, they clearly often have neurologic impact. And inflammation is important in them and important, you know, in cardiovascular disease. And, you know, so my guess is that I mean, that's one of the thoughts I think that is causing a lot of these problems is inflammation in general.
Yeah. There have been some important studies out of Mexico looking at distance from freeways and children's impact on the brain. Actually, what I didn't realize, Lori, is the researcher out of that Mexico study is actually at the University of Montana. So these things seem to me very important across many diseases.
Yeah, I'm sort of surprised that that looks like that looks like it's the extent of the rheumatologic literature on air pollution. Is that correct?
It's pretty much, I
Yeah.
mean, and it has, you know, it sort of started in 2009 and kind of kept going up. Yeah, and much of it is much more recent. The stuff that looks like there's a connection is more recent, other than the traffic business.
Right. I mean, I think, you know, cardiovascular disease is just so common. It's much easier to study because you're going to have, you know, much more people affected, and we see such clear effects from the inflammation and on the brain and on the fetus. I mean, it's only natural, and I can't imagine that we're not going to find more stuff in the rheumatologic and immunologic field. Sarah, given that you do research in rheumatologic disease, what's your thoughts on this?
This is my first time hearing about air pollution as a risk factor, but this makes sense. I mean, this confirmed a lot of like what I knew with, you know, there's association with like lower socioeconomic status and rheumatologic disease, but there's not really, we don't know why yet, and there's just not a ton of research out there on rheumatology compared to other fields. So I'm interested in, you know, learning more about this. Yeah, I study like pregnant people who have lupus mostly. So yeah, just for like some context about what I study. And we definitely track smoking as a risk factor. But yeah, now I'm interested in maybe talking to my PI about air pollution as well.
Well, and socioeconomic status is also associated with people living closer to traffic. You know, I mean,
Yeah.
so there were, it wasn't 100% coincident, but they were saying that that's probably one of the reason, that could well be one of the reasons that people with lower socioeconomic status have more rheumatologic disease and more other diseases as well, you know.
Yeah. Catherine?
Well, I had a comment on a couple of things. It seemed to me that if you have a higher percentage of people living closer to heavy traffic, that would account for just in itself for the higher instance of rheumatological disease among lower income people. It seems to me, and I had always assumed that there was a higher percentage of them living, you know, closer, because that's where the cheapest rents are and things like that, is near heavy traffic. But I wanted to ask both about the ultrafine particles and the greater than PM10. I don't know where to start. I'm also curious to know why. Robin, you had mentioned that the PM 2.5 had brain impacts, and I'd love to know more of what the brain impacts of that were. But also, I think you mentioned in another chat that there were effects from greater than PM10, and I thought that the particles had to be PM 2.5 or smaller just to get into the bloodstream to create effects. I mean, I guess that PM10 and anything larger than 2.5 can degrade lung tissue, but in terms, I mean, they've got to be 2.5 or smaller, I thought, to get through the alveoli, to get into the bloodstream, to get to the brain and to create other effects. Do you know?
Actually, the ultrafine particles are actually direct impacts on the brain through the olfactory apparatus. So we actually directly breathe those in, although the inflammatory impacts are both through the vascular distribution and to the brain and breakdown of blood-brain barrier. But that was, Kathy, I was really kind of interested when you said that this showed up in PM10, but not 2.5. And I presume that has to do,
I'm sorry, go ahead.
That with the wide range of the pollutants that are across the studies.
Yeah, I mean, some of the studies did show 2.5 and some showed 10 and some only measured 10. Some of them, they didn't even look at 2.5. So, I mean, I think, you know, this stuff is just really beginning.
Well, how would the PM10 have created an effect if it can't get in the bloodstream?
Well, it can get to the lungs and cause damage there and
the lungs.
initiate an inflammatory response there. I mean, silica
Ah,
can do it, you know.
and those are probably pretty large
Yeah.
particles, I would think.
Yeah.
Interesting. Wow. Wow.
So, I mean, no more studies need to be done and all that. And, you know, I don't think rheumatologic disease is the biggest harm that air pollutants cause. I mean, you know, I think, but, you know, it's interesting that it is one of the things that it does, that it seems to do.
Just continues the story of inequity over and over and over and over again.
Yes. Yes.
Yeah, and Kathy and others, it will be interesting to see what happens too, given that, you know, the new data from the past couple of years shows that wildfire smoke is even more toxic than particulate matter from other sources like traffic.
Wow.
It's not as chronic, it's more episodic, or at least in the past, it's been more episodic. And where that line or where that exposure duration is or makes a difference, it'll be interesting to see. And as we all know, interesting is never good for the patient.
Actually, John Baums, who is pulmonologist and on the California Air Resources Board, says that wildfire smoke is like smoking cigarettes without nicotine.
Wow. Why would that be without nicotine? Why?
Well, wildfire smoke doesn't have nicotine in it, but it has a whole lot of other pollutants.
So inhaling wildfire smoke is not addictive, but it just kills you sooner.
No withdrawal symptoms.
Cynthia, I expect that, don't remember the statistics, but I would expect that inflammatory related kidney disease is kind of a rare like rheumatologic disease, but are you aware if anybody has started looking at air pollution and kidney disease?
Interesting.
I am not aware of that. I know that there have been some associations with smoking and with, I'm trying to remember what the other air exposure was in terms of things like, not most chronic kidney disease, but some of the inflammatory things like polyarteritis nodosa. But I don't know that anybody's done, and I haven't kept up with the literature in the last 5 years, so I wouldn't say I'm the best source, because so much of this stuff is really just blossoming in the last 5 or 10 years, right? That we had no idea before that. So we were just blissfully ignorant of how much damage we were causing. And that made sense when fossil fuels were the only alternative, or coal or burning wood, which might be even worse, or burning houses and forests, which might be worse. But but now that we have alternatives, this stuff is all very, very interesting.
Interesting. That's an interesting way of framing it.
Now we know. It's
Bob,
a way
not
of,
to,
you know, not blaming people and making them feel bad that they've used these things, because I don't think that blame works, which is different than fossil fuel industry, which has willfully hidden known harms.
Bob Kitchen, do you recall the study that you all commissioned looking at the morbidity, mortality from traffic pollution that you all commissioned in Virginia, you know, in hopes of using that in legislature to convince people to electrify the transportation sector? Was the morbidity, mortality that was studied there, is that largely just cardiovascular and respiratory? Do you know?
I'm trying to think. I'd have to go back and look and see. You certainly have cardiovascular and respiratory. When you talked about the increase or the excess deaths that came from PM 2.5 exposure from transportation, because it drilled it down to Virginia specific transportation. You know, recognize that there was PM 2.5 from numerous sources, but this study was just specifically for transportation. And The slides that I've put together talked about cardiovascular disease, certainly asthma. I think it reflected fetal maternal. I'd have to go back and look at that. Don't hold me to it until I go back and look at the study. But yeah, bottom line was, yeah, PM 2.5 certainly caused excess deaths in Virginia.
Yeah, speaking of inequities, one of the big things here in California now is the distribution centers that are being built in the Central Valley and in the areas around Los Angeles. And I guess I'm weak on geography, Orange County, Riverside, that kind of thing, where they're creating these huge distribution centers, which then have tremendous amount of diesel truck pollution that's just adding to the inequities of people who live, poor people who are living in those areas and working in those areas, now exposed to more and more traffic pollution. So the clean car, and especially the clean heavy duty truck standards, will go a long way towards improving that.
Yeah, I was thinking, Kathy, that the fact that you have this increased rheumatoid arthritis in lower SES, it would be fascinating to have that broken down to rural and urban, because that would pretty well give you a picture of whether it's pollution related. So if it is pollution related, then we should see a whole lot. We should see normal amounts, I guess, in rural people.
Yeah, I didn't see that in the statistics, although I'll look at it again for that. Yeah.
And Yvonne, have you seen anything in, I guess, suppositions or theories as to, what's happening prenatally to lead to a preterm birth and smaller babies and that kind of stuff from air pollution? Have you seen anything on that, just as an obstetrician?
Absolutely. There's actually probably many articles that have pointed to the direct correlation of air pollutants and premature birth of babies, low birth weight for babies, stillbirth, some congenital abnormalities. So definitely there's correlation. There's also data that looks at, as we're talking about highways and the proximity and the subsequent effects from that, also some studies that are now pointing to those women that live closer to highways, the compromise of their fertility. So I think as we look at redlining and the whole effect of inappropriate housing for those vulnerable populations, we're going to see more and more the compromise of all systems related to air pollution near highways, but definitely lots of data on the reproductive front.
Yeah.
Yvonne, do you know if that applies to male fertility?
There's some data that looks at spermatogenesis and sperm maturation for men. Yes.
Equal opportunity. I'm sorry.
Yvonne, are you aware of, it sounds like it's probably, again, like almost all these other things, inflammatory based, but what's happening in the pregnant person with the air pollution to give rise to preterm birth or smaller babies?
Some of it has been linked to inflammatory, some not a direct correlation in terms of etiology. When we sort of take it to the next realm of heat, it's definitely due to abnormal vasculature and dehydration that leads to that preterm birth. A little bit about inflammation on the air pollutant side, but not as much as I think we've seen tonight related to inflammatory bowel disease and other immune-mediated diseases.
Wow. Well, this is fascinating, guys. Is there anything we should discuss in addition as a health team on just what's going on around the world, around the US?
Well, I'd be curious to know if anybody else has read anything about the effects of wildfire smoke. We haven't covered that yet, have we? I mean, I see that wildfires as a climate change related thing, and if we had a meeting on that, I missed it, and so ignore my question, but I'm wanted to know more.
Yeah,
Big
well,
topic.
Actually, Catherine, wildfires, despite the reduction in emissions in the U.S. nationally over the past couple decades, wildfires are reversing that now. They've actually been reversing it in the Northwest for some time, but they're reversing it nationally now because of the increased intensity and the acres burned and just the sheer volume of the wildfires themselves. And
Doesn't
so,
doesn't
like I
the
said, it's a good
ALA
study.
or the, oh, I'm sorry.
Go
I
ahead.
thought you were- doesn't the ALA or the consortium or both have some recent webinars about wildfire smoke?
They may well. I know, and it was from University of Colorado, but I'm not sure who sponsored it. There have been several, and happy to look for some of those because I saw a couple of them and should have the links for them.
And you're right, Catherine, we have now discussed that topic on CCL Health Calls. So that's a great suggestion.
Do you want to mention, Lori, our YouTube so that people know about that?
Yes, so we now have a YouTube channel and we're going to start putting the calls that we remember to record on them, assuming we have permission from Kathy Price and other speakers that we have in the future. So we just started, I think, with last month's call. Somebody else can talk and I'll try to find the channel.
Okay. Well, so Cynthia, I think it was you who mentioned ALA did studies on it, but I want to make sure that's American Lung Association.
Right, right.
Okay, thanks.
I'm not 100% sure, but I'm pretty sure because they've talked about that on their calls.
Ah, thanks.
Robin?
Wildfire has massive health impacts across many domains, and I think there are many talks on it. Thanks, Rob, for considering where those are. I just wanted to mention wildfires also have a very significant impact on mental health, both for those who have been experiencing wildfires, displacements, and permanent displacements from their homes and community impacts that are quite enormous. They contribute to eco-anxiety, the anticipation of what will happen in our world. But there's another aspect of wildfires that wildfire and health that's very, very under-recognized. And that's a really big mental health crisis among wildland firefighters.
Right.
Where we tend to make them into heroes, but we do not pay attention to the enormous toll on them. So I just wanted to bring that to the discussion.
Thank you. Not to mention the 10,000 prisoners that are firefighters in California.
And then
a couple more stress factors.
Which is like a form of slavery. They work enormously under enormous stressful conditions, and then they're not able to get jobs after they're released from prison, although they're skilled.
Didn't they just propose or pass something to where they could be employed in that as a firefighter when they get out of prison? I was thinking I read something recently.
Do you know whether that?
I don't know if it passed. I know there was a bill about that. I don't know if it passed.
There was a bill that supported peer supports for wildland firefighters in California, but I would suggest the mental health needs are much more significant and far-reaching than just peer support. This is far afield from Kathy, from your presentation.
But it all kind of ties together, right?
Right. And I mean, I think mental health is a big problem related to all kinds of climate change things. I mean, they talk about the anxiety that children have and adults, have about climate. So it's not limited to wildfires, it's everything.
Mhm.
So on a good front related to healthcare is that there really has been a lot more emphasis over the last few months, maybe year, between organizations that manage hospitals and looking at and looking at what hospitals can do. So this is a good thing. I'll put it out. I can't find it now, but I'll put it in. I'll make a forum note on it. The Agency for Healthcare Research and Quality, AHRQ, is starting a whole series on hospital sustainability, which is good. And the House Ways and Means Committee just had a special hearing last week, listening to some of the climate and health people and sustainability people. And then the Center for Medicaid, CMS, Medicare and Medicaid Services, who of course are hugely influential in what hospitals do, are looking also at ways to incentivize hospitals. Yes, Lisa.
On that note, we had a meeting with the Director of Sustainability at Henry Ford, which is one of the only hospitals in Michigan who's signed on to the HHS pledge to decarbonize. And when we talked to him, one of the things they said that I thought was extremely interesting was that whenever these volunteer initiatives come out of HHS, you can almost always bet that within a few years, they're going to be mandatory and linked to CMS reimbursement. And I
Wow.
thought that
Oh,
was really
wow.
interesting. And he said that that's why one of the reasons why they signed on is they wanted to be at the table rather than on the table. They wanted to be able to influence how that
Wow.
rolls out. And I just thought that was a really interesting perspective.
Yeah, that's nice news to hear. Any other nice news in 2 minutes or less?
I'm sorry, I'm not laughing about what you said. I'm laughing about the chatterbox table.
Why are we not surprised?
It was good training.
Kathy, this was wonderful. Thank you so much for putting it all together. That's
Yeah.
tremendous amount of information, but really
Good.
helpful.
Good. I'm glad you liked it.
Thank you, Kathy.
Okay,
Really
thank you.
appreciate
Thank you
it.
very much.
It really helps broaden the picture and the scope of things. That's useful.
Come back, Sarah,
Yes.
and good to see everybody.
Stay safe.
Yes,
Okay.
indeed.
Bye.
All right.
Bye-bye.
See you next
Bye.
time.
You guys.
Bye-bye.
Thank you.